This is Daybreak, and thank you for staying with us. The hashtag on X is Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. We now shift our attention to fighting or combating HIV and AIDS in the country. With me in the studio is Wilfresha Osore. She is the lead community nurse at Baraka Health Center. Thank you for your time at the center. Next to her is Odhiambo Otieno. He is a communication expert. Thanks for your time. And on my immediate right is Mary Nyaguthi, who is a preventive program manager at the AHF Kenya here in the country. Thanks for your time, ladies and gentlemen. Much appreciated. Thank you. First, I begin with you, Mary, and as a preventive officer, I mean, among the adolescents is where the key concern is now at the moment. What are the preventive mechanisms that ought to be adopted from the perspective of you being the prevention officer at your organization to address this very glaring problem amongst the community?
Thank you so much, Abdi, and good morning, everyone. Like you said, it's a bit worrying when you look at the young people, because when you're talking about, in terms of data, 10 to 19-year-olds, we have 62 new HIV infections per week. That is a bit worrying. So it's very key for us to work with the young people. The young people always say there's nothing for us without them. As an organization, AHF, what we have done is something we call peer-led intervention, whereby the young people have to be involved in terms of their planning, so that they understand what works for them, how they want the interventions to be delivered to them. They are involved in the implementation. They are involved in the monitoring and evaluation. So there's ownership in it all. It's very actually glaring, because if you look at the vulnerabilities the young people like we have in this current age, it's very different from where we are. It may be 10 years ago. So it's a big focus where we sit down and say, can we work with the young people? Like for the girls, we have a program called the Girls Act. These are safe space where we give the girls to sit down with them, address their vulnerabilities, and be able to work up a clear program for them. Yes.
Wilfresha, coming to you. I mean, as a nurse who is in the midst of, who is in the war zone, literally, and you have your day-to-day interaction with these patients, is there adherence to the treatment for HIV and AIDS patients?
Yeah, I can say that there is adherence, and to some patients, there is adherence. Right now, we are looking at 95-95, 95 suppression, 95 missing pills, and 95-0 missed appointment. So I think there is adherence, and we need to emphasize more so that we reach at 100% to get at 100%.
And how do you then encourage for those who normally miss out on the drugs and on the treatment, because it's very key that they visit any other outlets or even where you are at the moment as the lead nurse?
Well, there is some people who are missing appointment, and they have various reasons as to why they miss appointment. The key part of it is the lifestyle. The tough economic time in the country makes these people to miss appointment, because they're saying they cannot go to take medication on an empty stomach. So they go for work, do the casual works, so that they can get something to eat before they take medication. It is still a challenge, and we are fighting about it.
We'll talk more about the needed messaging and why it's very key for them to get to treatment or healthcare centers. Odhiambo, coming to you, how then is the packaging of the messaging around HIV and AIDS for the young people?
Thank you very much for this opportunity. It is, first of all, important to note that the packaging is extremely poor amongst, or for this particular group of 10 to 19 years of age. Having worked with these youths for the past 5 years under the Ida Odinga Trust, we were running a campaign called Linda Kesho. And we realized when we went out, initially we went with the message of abstinence. But when we sat with them, they told us, no, let us teach you what to tell us. Because abstinence is no longer in the picture. They are moving into actual activity. And so with this actual activity, it implies that the messaging has to be repackaged. For now, everybody, or rather a large percentage of the NGOs are trying to facilitate pills, preventive measures, okay? But you find these youths, one, in terms of communication, they are not so much on TV.
Yeah.
Neither are they so much on newspaper.
Yeah.
But they're on radio.
On social media.
And on social media.
Yeah.
You will agree with me that radio, a large percentage of it, the messaging at this particular moment, between 6 to 10 a.m., which is what we call the prime time, is not about educative issues. We are talking about things that actually facilitate sexual activities amongst the youth. Now, social media is proliferated with funny messages. If you talk about TikTok, for example, we have between 7 and 10 or 11 p.m. where we have obscene messages. And a large percentage of the people who are in that space are these youths. But is there somebody who is giving an alternate message? There's none. So this message is sinking quite clearly amongst this generation, and they are taking it in and proceeding to involve in sexual activity. And that is why, as we were discussing before we came in, we found a similarity that between 10 and 19 are now the new front of infection in HIV. The next front is between 19 to 24, especially for ladies. And this is because of intergenerational sex. Okay. Now, let's say that between 10 to 24, and especially on the female side, is now the front that is going to drag us back. Because as you're aware, 78% of people living with HIV are on medication. 22% who are not aware that they're HIV positive and who are not on medication are what I call the loose atoms, moving up and down, having this intergenerational sex, and also lack of this proper messaging going into the younger generation. So in terms of packaging, it is poor.
Then how do you counter? Because that is by making an admission, then therefore you have to counter the messaging, because now it seems the attention has moved to social media where they can get the information that they want depending on the algorithm, because TikTok often gives you, depending on the algorithm, what you like watching. I mean, how do you then counter that?
Now, that is the important bit. That's why we are saying, as of now, most of these organizations, or if not all of them, and the government taking the lead, should have a sort of a convergence body where we have all these NGO actors and the state sitting at one table, having to review what steps have we made this far in terms of communication. Because up to this moment, everybody's doing their own thing. And as you're aware, unlike my sister here, or my sisters here, most of these organizations are doing hotel-based advocacy, which is wrong. We should be down on the ground. I've done this thing for 5 years, talking to these kids. And for these 5 years, I never saw one particular organization join us on the ground. But they would invite us to hotels. So we must shift from hotel-based advocacy. Let us converge nationally. Once we've converged nationally, let us have harmony of policy in terms of communication. And let us stop burning so much money on what I call non-essential communication. Let us move to social media. This is where these people are. This is where they want to be. And let us move to schools, because these people are in schools and universities. Okay? There are no programs running in schools and universities today. We don't have the popular health clubs that were there before. Why can't we reintroduce them? Okay. Thank you.
And actually, just adding to what he's talking about, communication package. Because we talked about the adherence, especially when you look at the young people, it's really poor. And the focus is, like you have said, the young people are in the social media space. And right now the biggest challenge we're having, we're in the holiday season. There's something we call, the young people call it a drag holiday or a Christmas break. But when it comes to ARVs, there's no Christmas break. You have to continually take your ARVs every day for good adherence. That means, how do we tap into social media? And like you've said, TikTok is the new thing. You've talked about peer-led interventions. You've talked about us going to the grassroots. That means we have to identify the people in the community who are their role model or key advocacy members who will be able to influence, who will be able to educate them, and use, for example, like you've said, a social media platform for us to be able to reach that message to them, for us to enable them not to take a drag holiday for improved adherence.
And would that not bring about the aspect of stigma?
Actually, the theme for World AIDS Day this year is community-led interventions. Yeah. He's talked about, we leave the hotel meetings, the high-level meetings. We just have that meeting and go back to the grassroots. We have to go back to the community. The communities are, some of them are people living with HIV. It's peer-led interventions. They understand, and that's how we are going to break the stigma. Because when we sit in the hotels, when we say we are having the young people interventions, and then we release them back to the communities, that means we have to strengthen the community so that when they go back home, their guardians, their communities understand, and we'll be breaking the stigma. Yeah. How we break the stigma is talk about it until it becomes normal. Where we started initially when it comes to HIV testing, you'd pitch a tent, nobody would come. Nowadays, people are willing to come for HIV testing. That means we have made great milestone in terms of reducing the stigma. And
demystifying the deeply held
the deeply held perception.
Okay.
Yes.
Well, Fresha, I mean, how key is the involvement of the community here?
The involvement in the community is very minimal, I will say like that, because they lack education. People in the community, some lack awareness. And that is why the stigma is coming up. They are not ready to expose themselves or to share their lifestyle or their status. But the only thing that we can do here is just to bring the education on the ground. As like my sisters have said, we leave these hotel things and we go to the ground. We start by educating them. When a patient gets proper preparation session, we call it TPS, that is treatment preparation sessions. We need to educate. You start by telling this patient that HIV, the meaning of HIV, let this patient understand the HIV, the role, what it's going to do, how to live with it, how to take medication, the CD4, the viral load, the treatment failure when he fails to take medication, what are the repercussions. All those, you package them and let this patient get the full information. This, when you start with the patient like that, the patient will be able to continue. That stigma, you start day one addressing the stigma. And after that, continue following up. Yes. Talk about the nutrition. Talk about how this patient, the psychosocial life this patient should live with. When you ensure all that, I tell you this, this patient will adhere to the treatment. And if there is any disconnect between the information and the patient, finally, this patient will get lost to follow up, or will stop medication. And the thing that will get at the end is death. And that is why we are trying to be on the ground and to start talking about the HIV from day one this patient is tested positive.
Odhiambo, I mean, how then do the organizations here and the national government, of course, engage in the rolling out of help for those who much need it? And what informs, in your view, one region probably having more infections than the other? I mean, what are some of the factors that lead to that?
Thank you. These are two very powerful questions, but let me start with the initial one, which is how does the government then come in to help those who need this help? We have a golden opportunity with people we call CHVs, all right? In every community today, and that is out of devolution, we're having somebody who at least knows something about the community they live in. But I tell you, having worked also in a county government before, when it just started, we realized that these CHVs are greatly underutilized. They're not trained. The model that I suggest that the government should take moving forward is, can we have training institutions like the universities and colleges, and maybe KMTC, train these CHVs to become CNAs. Let us not just have CHVs, because CHVs, the information about particular infections are very limited. But let's push them, or let's upgrade them to become certified nursing assistants, just like we have in the US or UK. And certified nursing assistants are people who are actually qualified to provide particular counseling or health support. Now, once we have these CNAs, or these CHVs upgraded to CNAs, we are able to have them help people like my sister here in terms of ensuring adherence, or even in terms of promoting communication at the ground. Because you're aware, with media, we can do just so much. The real work is at what I call alternative media channels. And alternative media channels, I'm talking about the African traditional system, where we used to have barazas. Can these CNAs, I'm calling them CNAs because I'm looking at the future. Can we have these CNAs hold barazas with 10 families, like we have the Nyumba Kumi system in Tanzania, which is very effective? Can we adopt that here, and have it run? Now, to your second point, when we are talking about having this particular generation of youths becoming so much aware or involving properly in these issues, one is we have to improve what I call comprehensive sexual reproductive education. Up to this moment, what we have is what I call anatomy. Children are taught this is how the genitals look like, and this is how the male and female look like, but they're not told what else, what happens. We are ignoring something here. Comprehensive sexual reproductive health cannot proceed if it is not infused at the initial stages of education, of learning, which is between 6, 7, 8, 9, 10 years, which at this moment is completely ignored. So we need to adjust that.
Mary, coming to you, I mean, the numbers that Odhiambo talked about, 10 to 19, that points to parental crisis, is it?
Yes, it's both. Because if you look at 10 to 19, most of them are either in, a 10-year-old is either grade 4, 5 there, and a 19 is almost secondary school in the formal platform. So you're looking at 10 to 19, whereby what is making them be vulnerable? And you ask, what is making the infection in one region be higher than in another? But I look at it, what is the vulnerabilities in the various regions? Let's say, for example, Nairobi. What makes a 10 and a 15-year-old girl be more vulnerable in Nairobi? Maybe she wants to fit into a specific lifestyle. What makes a girl, maybe, for example, in Kisumu, to be vulnerable? Maybe who does she want to relate? So there's a lot of peer pressure. So we are talking about, I know we have talked about whereby parenting, we have left it to the teachers. We have left that to the teachers. I always say the best package is, when I was growing up, the responsibility of bringing up a child was a community effort, whereby your neighbor would actually discipline you. We are going back to, we are emphasizing on the need of the child, the girl child and the boys are not comfortable talking to their parents. Remember when you used to have the uncle system, whereby I would be more close to my auntie, I would disclose my fears to them. So we are taking back the parenting to the parents and also bringing up a child as a community. That's where the focus, the talk right now is all over community perspective. Let's take back. I always say HIV is a social disease and we cannot manage HIV in hotels, at healthcare facilities. We have to go back to the community. And I like actually the other day as an organization, AHF, we celebrated 15 years. And the theme was it is not over. Because like the discussion we are talking here, there's a lot to be done. That means we still have to invest in HIV.
Well, Fresha, this 10 to 19, the teen crisis, does it also point to the economic aspect here, of the social economy of the society, where in many aspects vulnerable girls are exposed and therefore they are taken advantage of? Is that gullibility also a cause of why we have this rise in infections amongst that age group?
Yes, because as she has said, these girls in the community, they lack a lot of things. And the social aspect of it, after lacking and they are seeing somebody with a smartphone, a big iPhone, the hairstyle, so she'll admire. She as a person, she'll admire. And the parents and the family, if they cannot provide, who is the next step? The sugar daddies. And after that, you know the sugar daddy will give money, and there is no way that this vulnerable girl will tell this baba that we go for a test or we use a condom. So there is this, I give you the money, you give me the service, you don't know my status, and after all, she has left you everything. Because this young girl cannot stand up for herself, to defend herself, because she's vulnerable. So vulnerability also...
she might actually just be looking for 50 shillings to buy a sanitary pad.
A sanitary pad.
Which exposes her.
It exposes her.
And many other girls across the country. And even as we do that, or the unborn, and this becoming another forefront in the crisis in regards to the high number of infections that we continue to record, what then needs to happen from two perspectives? From the parental level, that's one, and then two, from the societal level. I mean, is time ripe enough for the free distribution of pads to all school-going girls to address such a crisis? Because if that is sorted, then it means that we are addressing the vulnerable nature of girls who will be exposed otherwise if they lack pads.
Let me say this, that one, starting with the last question, if we're talking about the provision of pads, in my view, it shouldn't be just about school-going girls. It should be about every woman who is not able to access pads. Because menstruation is not a choice. I'm a man and I know that, okay? But deciding to go and have sex is a choice. So every woman in that spectrum, because we're not looking at reducing infection of HIV among school-going girls. We're looking at reducing HIV infection across the spectrum. So if it is about pads, let's provide pads to every woman who is unable to. In fact, I think we should just have a pad factory somewhere in Kenya that is properly subsidized or properly financed by the government. We have so much money to waste, and you're aware of that. Two, parental crisis is a big issue. As my sisters here noted, and I told you, when I started this campaign of Linda Kesho, we realized that there is a problem here. And I will tell you, because you may know, that when we were growing up, most of us, we used to eat, children will eat alone, and mother and father will eat on the table alone. Now, that is the beginning of the problem, because you don't know your children, okay? And some parents are administrators. They act like policemen. When they walk through the gates or the door of the house, everybody runs away. Your child is scared to even share with you a boyfriend that they're having, or a girlfriend that they're having. But you see, this is reality. They're having these boyfriends and girlfriends. We used to have them, okay? Now, if you block a child from sharing with you because you think that a family is run in a government sort of way, then you're losing them. That's number one. Two, in that perspective, disintegration of the family structure. As you rightly pointed out, initially, we used to have the extended family. Because if you get married, or when you get married, you're getting married into a family. You're not getting married to an individual. But this generation, all right, it is about, I'm getting married to that. Na mami, nyanya na guka ni watu wa kupiga zile vitu za superstition. Utarogwa ukienda nyumbani. It is wrong. So disintegration of the family is a big contributor. Right now, we have single mother-led families or single father-led families. Who is going to bring up this child to be a wholesome a human being in the community? So we are having a big crisis, and unless it is faced, we are going to have a big problem still. Okay, thank you.
Mary, talk to me about the concerning trends based on the recent report by the national, that's NSDCC, and generally, again, what comes up is the youth crisis. I mean, when it comes to unemployment, they are on the brink. When it comes to HIV and AIDS, they still are cited adversely in this report. What then can be done? How should the messaging be then? I mean,
okay, like you said, it's worrying. But one thing I have to celebrate: we have made great milestone. We have, we have improved, because if we look at where we were 2010 and where we are right now. Right now, by 2020, we are talking about roughly 22,000 new infections in the country. But now, out of those 62, between the 10 and 19 per week. It's a bit worrying. That means we have to bring the young people in the decision-making table, not us as programmers and sit and think, oh, this will work for them. We don't know whether that will work for them. As a communication expert, he'll tell you, how communication is packaged for Nairobi people is very different how it is packaged for the the Western region. And we have seen the dynamics are evolving. We have seen counties that were actually not in the map coming up and having new infection. Like we've seen Madeira actually in the map. We have seen the new infections go up. So the trends are a bit changing. That means when it comes to HIV programming, it has to be dynamic. It has to be continuous monitoring. Is this strategy working? No. If it's not working, can we sit down and make a decision and re-strategize? But not as programmers. We have to involve the communities of people living with HIV. We have to involve the specific cohort that we are targeting. If we are targeting the young people, we have to work with them. If we are working with them, maybe, for example, 19 to 24, the dynamics are different. Actually, when you look at the cascade for 10 to 24, you cannot have one package, because their level of maybe understanding is very different. So how we usually break it down is 10 to 14, 14 to 19, then 19 to 24. Because if you're looking at 19 to 24, like what we are talking about, socioeconomic is very key. Because a 19 is someone who is from high school.
Fresh from high school,
Fresh from high school. They want a source of income. Remember when we were Form 4, you needed some money. So what we are doing is, how do we start income generating activities, which are homegrown and they're sustainable to them? Because I can sit here and say, let me give them seed capital. But you know that dependency syndrome. But we want to have them own that intervention. Like, for example, in Nairobi, we are working with them for urban farming. You know, urban farming is a very key thing. But they are the ones who are source of labor. It gives them ownership. So different cohorts are very different. And we have said, when I look at HIV where we are at, I look at it as like a fragile egg. We have made great progress, but if we don't focus, we are going to lose the ball and we are going to move backwards.
Well, Fresha, take us through practically the treatment preparation session for an HIV and AIDS patient.
Okay. We normally get these patients from service delivery. And when they have seen the doctor have taken them to the counselor, the tests have been done, and now this patient has turned positive. That is where the problem starts. When you turn positive, I want to tell you this for free, because there will be a lot of things that will run in your mind. Where have I gotten this? How am I going to live with it? How is the community going to take me? You know, HIV is normally associated with prostitution. So most of people will say, oh, I have been doing prostitution. So that is the thing that ran out of their mind. So the only thing that to curb this client and remove all these questions is where we start with treatment preparation session. We call the patient, we sit with the patient, we talk about it, telling him that having an HIV is not the end of life. In fact, it is a beginning of life. Me, I would say, if I'm given HIV and cancer, I take HIV. Why? Ask me why. Because if I take my medication very well, I will live longer. But take cancer patients. Things get tough on the way. But so you need to bring this patient on board. You prepare this patient very well from day one. You bring all those practical aspects. You tell him or her that taking medication, if you take your medication very well, you will live like any other normal person. You will go to school if you are a child. You will give birth. You will go abroad. Me, I have gone abroad, but I have never, in the airport, I haven't seen somewhere asking me about HIV certificate, but COVID, they ask. So you tell those people the practical part of it and the real essence of taking medication and staying good life.
Yes, Mary, I'll come to you.
Yes, just to add on treatment preparation. You know, something we have seen even in our clinic setup. There are those patients who believe, I'm taking this medication, they have to own. Once they own and commit, I'm taking this ARV because it's beneficial to me. That's why the preparation is very key. And it's not a one-off, it's a continuous process. Every time they come. And that's why it's very key for the patients to have what we call psychosocial support group, where they come sit together, they share what are the challenges that that everyone is facing. It makes them improve adherence. But the patient has to own. You know that those, even during, there are those who we lose, those lost to follow-up. When you trace them, they think actually they're doing the nurse or the CHV a favor, coming back to treatment. That means that is a patient who is not committed to taking ARVs. But once they know I'm taking this because it's beneficial to me, they own it. Yes.
Odhiambo.
Yes.
What then are some of the factors that you can line out which breaks the line of communication?
Well, we have, as we've said before, the issue of stigma, which is very real. 2, we are having over-reliance on traditional media or mainstream media, let me name it as such. Over-reliance on mainstream media to pass these messages, whereas these people are not on those platforms, as I said before. Another one is the parental gap, which is in existence, and I've explained that properly. The other issue is we are having what we were talking about in the room, which is the intergenerational sex. There's a lot of a blind spot in terms of socioeconomics when we come to communication. You're aware that for you to make some particular decisions, even if it is in regards to communication, the facilitators of the process must be as pure as possible. But if the process is already riddled with issues such as lack of money, issues such as competition, pop culture, where we were saying that, for example, today, maybe because of where you work, you're very able to afford a very nice phone like the one I see you're having. But you'll agree with me, it was very difficult for you to have that phone. It took you some time. But look at the youths today. These ones we're talking about between the ages of 18 to 24 or even 29. These people are having serious iPhones, and they're not working. Where are they getting these things from?
The source is questionable.
Questionable. So that questionability of the source is noise to communication. And that then brings this blockage. But as I say that, I also want to add something on what my sister was saying here. That to increase uptake of testing, or even just prevention, then testing, and then the treatment, we must make this process as fashionable as possible. In the 1970s and 80s, I was not born then, but I am aware that dressing up in miniskirts was something that was frowned upon. But today is the top fashion. People can dress in it, We can make treatment very fashionable. The problem is we have branded treatment or the HIV process as a death statement. So as you go into it, it's a rehabilitation process. Nobody really loves rehabilitation, They go in it because somebody suggested, not because of their own will. We can make this process as fashionable as possible by developing proper communication strategies of having HIV/AIDS champions. We have people who have lived with the virus for very long time. Can we have them come out on social media through a proper package, Produce videos. Can they be on some particular TV show or some particular radio show where they talk about conquering this? And actually, treatment is not a rehabilitation process, or neither is it a death statement. Making the treatment as fashionable as possible is going to help us reduce, the issue of new HIV infections, which he's saying is 62 per week.
62 per week for the young people.
For the young people. And 62
cases.
62 cases per week.
It's also going to help us increase testing for those who may be aware. Once somebody is aware that they can go for tests and know their status, it will be very easy for them, because it's fashionable. Numenta test, this is my test, they show it all over, I'm positive, I'm negative, I'm starting my medication tomorrow. Make it fashionable. I don't know why we're burning so much money. That's my question.
We need to make it fashionable, especially for the men.
Yes.
You know how hard it is to get the men to test?
It is difficult.
It is very difficult. So I like that. We need to. How do we make it fashionable? How do we have a package for the men? Like I remember for HF, we are starting another program called Boys to Men, because you have seen how do we help the young man transition from a boy to a child. And I remember at workplace, we were told, you know what, it's going to be a men-led. Actually, it's the men who are leading that. So we need packaging that are really fashionable to attract the specific cohorts that we are looking at. Yes.
All right, and on you, Will Fresher, is the funding right? I mean, when we talk about all these problems, the communication channel that ought to be established, which ought to be two-way, talking about the question of this target group of people who are very young, the messaging question that you have talked about, is the funding right? Is it adequate?
I can say it is not adequate because there is somewhere that we lack. Yeah. When you lack this money to do this, to do the supporting group, to ensure that people, to do this, all this gathering, you cannot call somebody or a youth, you come and sit with her the whole day, and then maybe you leave, or the caregiver, and you leave that person going away without anything. And she has stayed with you the whole day. So for me, I will say that we have the funding, yes, but we need to use it more on this program so that when they have, they can use it for that money for the caregivers.
Mm-hmm.
Yeah.
Okay.
Maybe to add on that.
Yes, yes.
Abdi, Kenya is highly donor dependent.
Yeah.
I think
donor dependent.
Donor dependent. Above 70%.
We just had a climate conversation. We still depend on them.
Exactly.
Yeah.
It's highly above 70% donor dependent.
Okay.
Right now, the focus is where is domestic financing? Mm-hmm. International funding is dwindling. Mm-hmm. Anyone working in the NGO sector knows that the funding is going down. So, as a country, the question is, when are we going to invest in HIV? HIV, TB, malaria are highly donor dependent. So right now the focus is domestic financing. Because as the funding is going down, that means the HIV management is being transitioned to the countries.
Thank you.
Yes.
Let me get the final word to Odhiambo.
Yeah, let me say this. I just wanted to say that you got it right out of my mouth. One, I strongly believe that the funding that we have is adequate, both domestically and what we have received. It is very adequate. The problem we have in this country, especially to health, is abuse of our offices. We are having a big issue with the eating problem. People, you will find that towards the end of every financial year, NGOs are burning super money in big hotels and useless conferences. We have a lot of money. The problem is we have the eating culture in Kenya. Yeah. They want to eat even money for people living with HIV. Yeah. This one, if we eat this money, we're not focusing on prevention. We're not focusing on testing. We are focusing on
mixed up.
We are mixed up. That's what I'm saying. Can we have harmony of these actors who are all playing within the HIV prevention and treatment on one table? Then we harmonize even the finances. Otherwise, the eating culture is huge, Ayub. People are eating. NGO people are driving big cars. Yeah. Money that should be directed to actual services are being misappropriated, and that is the challenge.
I mean, is it then cash cowing on even the sick?
It is big.
The culture of corruption extending over to even the sick.
Absolutely.
Okay. That's how the focus is. That's why we're moving the focus, like you said. Let's abort the hotels.
Yeah.
We do community system strengthening. Because you see, once we involve the communities, they are the ones who are going to involve in monitoring and evaluation. They'll keep an eye and will reduce the misappropriation of resources or misuse of resources, and will ensure it's prioritized to the right people. But we have to move from up here to the community. We have to go back to the grassroots. Yeah. Yes.
Wilfresh, one final question. The retention of your patients. How key are they? I mean, what's your, besides Odhiambo coming up with a communication channel to reach out to those who are outside, in the context of them coming to these healthcare centers, for example, where you are, what's your level of communication? What's your retention rate? I mean, how is their feedback after the medication?
Their feedback is good, because there is somebody who started, maybe she has been on treatment for like 25 years, and now they're doing fine. They have no opportunistic infection. So for me, I will say that for such a person who has adhered well, the retention is very good for the people who are living with HIV.
And in that context then, I mean, are you happy? Is there a sense of demystification going on to the extent that there is acceptability on their part? I mean, once they are administered, once they are on the drugs, is there a degree of acceptability, them coming to terms with the real reality that they can live with the virus if they properly adhere to the procedures of the medication? Yeah,
in fact, they are our mentors.
Yeah.
Those people who have stayed on medication for long and they retained the medication very well, they are our mentors who mentor these these new patients who are starting the ARVs. So they have that capability.
Yeah.
They know that with acceptance, they will stay longer on medication. Yes.
And as we finish up with the Ambo, is it proper? I mean, how does it help in the establishment of that communication channel to use people, for example, Wilfresha points out, as who have been on the drugs for some time and are willing to be goodwill ambassadors? Will the messaging resonate even more when it comes from them?
Let me tell you, people in communication, we talk of the issue of identity.
Yeah.
People buy because they identify with.
Yeah.
So if they don't identify with the person bringing the message, then whatever we're trying to do is a flop. But from what I'm saying and from what we are all agreeing on here, is that if we have these familiar faces on the ground, familiar faces, we're talking about those who you know, this is so-and-so who stays at corner A. This so-and-so who stays at plot B is coming to the baraza. And I'm advocating for the baraza because once the community owns this is our patient, we are going to take care of him. Africa is about Ubuntu. We will take care of our people. And this will work because people love their own, okay? If we push this to billboards, big money adverts, which are not going to bring the direct impact to these people, we are wasting a lot of time, of course.
Okay. Final word, Mary. What the general messaging ahead of World AIDS Day?
My general message is it's not over. We still have a lot to do. Like we have seen, it's yet an imbalanced situation. So we need to invest in HIV programming. We need to push for domestic financing to reduce for us to being donor dependent. But very evidence-based strategies that are working is we have to go back to the communities. We have to involve our communities, the communities of people living with HIV. Yeah. We have to strengthen such that when we transition the young people from the health facility, they have a safe space to go to the community, to the parents and to the guardians who understand what they are going through and they are going to support them. Okay. Yes.
Your time is all appreciated. And talking about your final comments here, Wilfresha, then going forward, are we likely to see more and more people who are HIV positive coming out to, besides the reality, also be public about the consumption of the drugs that they take? And because, in other words, we have seen, as Mary had mentioned, many of them who are coming to do the tests now, as wasn't the case initially. Are we likely to also see people who are coming forth and adhere to the procedure of the treatment and be public about the same in using their drugs and taking the order as prescribed by the doctor?
Yeah, because those people have said the mentors. We call them mentors. Those are the people that even they're ready to come up and say, today I'm taking my medication. Today, if I don't take my medication, these are the repercussions. So in future, I'm saying the stigma is now going down and they will pick up, and they're the people that also they're educating the new people with new viruses so that there is life after contracting HIV.
That's right.
Yeah.
Yes, please, you can pick up.
Yes, my final statement will be this, Abdi. One, researchers and the health players, especially at government and research institutions, must not ignore a very key population which we are denying. Deniability is wrong. This is the LGBTQ community. We cannot avoid them because they're a player in new HIV infections. Let us focus on them. And number two, let us focus on ensuring that we go back to the community. Tutoke kwa mahoteli, turudi kwa vijiji. Asante sana.
Thank you.
Okay. Yes, Mary, on the milestones and the pending challenges?
The milestone, yes, we have made great milestone, but the biggest challenge, like you said, the role of prevention is to identify and also close the tap. But if you look at the maternal to child transmission, I think COVID hit us very hard. We had some time back industrial crisis, whereby the mother to child transmission, we had to achieve the global target of 5%. We are at 8.6%. That means in this day and age, we still have children being born with HIV, which to me, I'm sorry to say, is the criminal offense. it's preventable.
Okay.
That means we have to reduce missed opportunities. That means a mother in the community. And now the focus again goes back to the community. Because through the community household, you're able to know who is pregnant. We need to focus on them. So we need to reduce the missed opportunities. That's one of the biggest challenges we are having.
Yeah.
We need to invest domestic financing. We need to prioritize it. And like my fellow brother have said, once the funds are available, please, let's reduce these crack holes whereby we are misusing the resources. Let the resources be tailored to the right population.
Thank you. Wilfred Shausore is the lead community nurse at Baraka Health Center. Thanks for your time. Odhiambo Otieno is communication commentator, and Mary Nyaguthi is the prevention program manager at AHF Kenya. Thanks for your time, and looking forward to World AIDS Day, and much appreciated as you take the messaging forth.
Thank you very much.
Thanks to you too for waking up with us here on the broadcast. And up to this point, the hashtag on X has been Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. We'll see you on Friday here on the broadcast. Good morning.